Hi, I'm Sanjay, and my research delved into the medical field, and I want to explore treatment options that I found that Kawasaki's disease did not have. So, take for instance that imagine that you were a pediatric immunologist. It means you spent 4 years in med school. After 4 years of college, you spent several other years specializing in becoming a pediatrician, which means you specialize in childcare. And specifically, you want to specialize in immunology and you want to protect the immune systems of all these children. And say, for instance, one day, after years of practice, you have this 5-year-old boy come in and you're living in Boston, right? And this boy comes in with a high fever, he has rashes, a strawberry tongue, and you mistakenly identify this as scarlet fever. And at first, you give him the treatments of aspirin, but then eventually this fever is unremitting and effervescence does not happen. And so after years of monitoring, you find that his heart is tachycardic, meaning that his heart is beating abnormally fast. He develops more rashes, he develops rashes on his hands and his palms, and his fever does not go away. And after lab tests and a echocardiogram, which is an ultrasound of the heart, you find that he has Kawasaki's. So back in 1967, Tomisato Kawasaki first diagnosed Kawasaki's in a patient in Japan. And this was all compiled by a meta-analysis done by Jane Newberger in Boston. And she studied how this historical trend of Kawasaki's happened over time with new research. So after Kawasaki's first diagnosis, he thought it was mainly a fever problem, but eventually it became more clear that the cause of death was primarily due to heart problems, specifically coronary artery aneurysms. So to explain in detail, Kawasaki's disease is an autoimmune disease categorized by medium vessel vasculitis. What this means is that essentially for this disease, the body is allergic to itself, meaning that the white blood cells that usually help fight off pathogens, help build scar tissue, is attacking certain parts of the body for some unknown reason. And in Kawasaki's, this could happen and could be fatal when these white blood cells attack the arteries, the medium vessel size arteries. This is called vasculitis. And sometimes these attacks happen in the coronary arteries. So this photograph depicts the arteries, the LCA, the RCA, and the LAD. These are all names of arteries, and you can see it's bulging. And what's happening here is that white blood cells in a cytokine storm would kind of build, in a way, scar tissue inside these blood vessels, and it would inflame, and eventually it would bulge, and it would cause abnormal blood flow. This is extremely problematic when these aneurysms could burst, which would cause pericardial effusion, which is like blood pooling around the heart. It could cause muscle death, valvular regurgitation due to muscle death again, or cause just general problems and abnormalities with the function of the heart in later years. And so a study done by Cato, a long-term study, found that 30% of these children develop these fatal coronary aneurysms. 55% only 55% show improvement due to any treatment, and 1% of all children eventually go into death. And this is a problem because the study of Kawasaki's has been very limited, only existing in medical research for about 40 or 50 years. The causes are entirely unknown. The pathophysiology, how it works inside the body, is entirely hypothetical in theory, and people have linked bacterial infections that may have caused it, viral infections, or genes that make people more susceptible. However, all of these have been rejected by the meta-analysis done by Newberger. And this lack of research eventually leads this disease to have treatments that are also based on sort of trial and error empirical evidence. And the two treatments that have been going on for a time is IVIG and corticosteroids. So back to history, after Kawasaki diagnosed this disease the first time, the first treatment that was hypothesized was corticosteroids. This is maybe a synthetic hormone that acts inside the body, and it's also used for other types of vasculitis and autoimmune diseases, so it was a logical conclusion. However, a study done by Ferroccio back in 1984 found that IVIG was much more effective in eliminating these crucial coronary artery aneurysms. And further, Cato in 1979, back then, found that corticosteroids could actually have a worse effect on these aneurysms and worsen their effect on the children's lives. However, after many more years of research, we're beginning to find that a different side of the story is coming to light. In 2000, Yuhira found that corticosteroids along with IVIG was much more effective. Miura and Zhu also found that steroids coupled with IVIG or as alone is much better in eliminating these coronary artery aneurysms. So I mean, we have this dilemma, this controversy, because there are these two treatments and we don't know which one is more effective. There has been research on both sides saying this one's more effective, this one's more effective. And for example, Cato study rejecting steroids was actually very robust. It was an experimental study and it was very, very highly regarded upon as a very novel study for this disease. And so my research question eventually boils down to a few set terms. I'm going to assume that primary IVIG is the most effective treatment, but again, a study done by Yuhira found that 20 or 30% of all patients with IVIG are unresponsive to treatment. Therefore, my study compares steroids and IVIG as secondary measures to fight off coronary artery aneurysms for all Singaporean Kawasaki disease patients. And this is a flowchart depicting how this essentially works very simply. So where the use of steroids and IVIG are suggested towards children with Kawasaki's in Singapore, and the response variable would be a coronary artery inner diameters over time. To repeat, the aneurysms would often increase the size of the inner diameter, and thus it would be a very easy way to measure how bad Kawasaki's is. And this was eventually further solidified by a study by Dezorzi, which found that these aneurysms are the main reason why Kawasaki disease is so fatal. And so back to the topic, we're comparing IVIG and steroids. They're both treatments for a disease. And my thesis at the end of the project was that I found that they're actually, in the long term, equal in their outcomes, in their effectiveness of eliminating coronary artery abnormalities. My research was modeled off of Dezorzi's study in Boston back in 1998, and it's a retrospective observational study done in a clinical setting, meaning that it has 4 major points. First, it isn't experimental. Because Kawasaki is so limited in our knowledge, because we don't know how to give Kawasaki's to a patient, we don't know how to put them in a laboratory setting, we can't study from a pathophysiological standpoint, and also it's unethical, therefore an experimental study was not the most optimal choice. And also, it was retrospective because it takes years and years for it to manifold. It takes years of checks and echocardiograms to make sure there's nothing wrong. Thus, a study looking back in time would be more effective in terms of timeliness. And again, it's observational and clinical, meaning that while we can't make causal judgments, we can make inferences about actual patients in the real world and how they respond to treatment in the real world. And also, I use purely quantitative variables because I find that in this medical discipline, we often require stats evidence and mathematical certainty to make our judgments. And so the way I obtained my data was through this system called the Electronic Medical Records Exchange. And this was implemented in Singapore in 2003. And it was done by the Singapore Ministry of Health. And it was to ensure that the public health information and all the patient case notes were all collated electronically across all public hospitals. Thus, it was an easy way for me to access all these public hospital records. And so from there, from a simple keyword check, I would extract those receiving secondary steroid and those receiving secondary IVIG. There were 70 patients across 10 years that were unresponsive to IVIG in public hospitals in Singapore. And I would extract these 3 coronary artery diameters, the LCA, the RCA, and the LAD, and I would put them through a statistical comparison. But what I realized is that there is a flaw that is not so apparent. It isn't this simple. I mean, we have different patients of different sizes, some older, some younger, some bigger, some smaller, some taller, some heavier. And so we can't necessarily compare these inner diameters directly, right? And so I eventually came across a bunch of information as to how I can standardize this information to make more sense. The first would be up here, the body surface area. So instead of using height or weight as an indicator, I used the body surface area calculation done by Haycock, which is a way to essentially measure the metabolic mass of a person, how effectively they can really digest and process this treatment. So Haycock's formula was also used in many other studies done by Dezorzi, by Crandall, and Hahn, and these studies essentially just transfer the weight and height recorded into a different BSA number. And then, using McCrandall's standardization formulas, I would essentially find a mean and a standard deviation for any person with this certain BSA. So let's say we had a child that had like maybe an arbitrary 40 BSA, we would find the mean, the average diameter, and the standard deviation of the diameter for this patient with 40 BSA. And thus, it was an easy way to compare essentially how abnormal a patient's artery was. So for each patient, we would have a number judging how different they were from the average. And they were often maybe 2 standard deviations or 3 standard deviations above the average. And we take this information and we plug it back into our flow chart, and we have our final method. After we collect the 3 diameters, we standardize it, and we find the time to abnormality resolution, from the first indication of this abnormality to the last indication of this abnormality. And then we conduct the SATS tests. And this is a sample of my data taken from SPSS, which is the stats collating program that helps us make comparisons and inferences. And it has around 200 patients, which I eventually selected 70 from. And this would be the patient's ID, their initials, date of birth, their weight and height for the BSA, their measurements for the LCA, the Z-score, which is the standardization, and the RCA and the LED. And this would go on for up to like 20 measurements. I've seen up to maybe 24, but mostly they're around 12 measurements made over time. So thus we have this data of maybe 70 patients, 30 from people who received IVIG and 40 who received steroids. And we have this information as to how long each patient took to resolve their abnormalities. So in comparing corticosteroids and IVIG as secondary measures after failed IVIG, I found that they were equal and that there was no difference in artery aneurysm resolution. And how I got this result was through a Kaplan-Meier analysis that I conducted. It's a stats test analysis, which essentially plots the probability for one to reach resolution. And if you look at this graph, blue indicating IVIG and green indicating corticosteroids, we can actually see that there's a higher probability that IVIG patients take longer to resolve their abnormalities, and steroid patients take less probability to resolve faster. So this graph, off the top of my head, seems like corticosteroids is a better option. However, this stats test actually showed that this is entirely due to random chance. There's a 10% chance that this data could be randomly obtained from a sample in which there was no difference. So I mean, although this graph showed otherwise, the reality was that there was not enough evidence to point to the fact that these 2 treatments were different. But there's something missing here. There's a big area here, and I want to use this area to further validate my results. And the way I did this was, I wanted to make sure that my sample was essentially equal in every single important characteristic but the treatment, all these control variables. So my controls that I had was gender ratio, the type of Kawasaki's, whether it was the incomplete, atypical, or normal, how different the age at Kawasaki onset was, and the difference in the classical symptoms. And these 4 categories were found to be the most essential categories to keep in control by Beth and Neuberger study in 2004. And eventually I conducted stats tests on each one of these aspects, and I found that there was no difference in gender ratio, there was no difference in type, no difference in age, and no difference in symptoms. So essentially, statistically, these 2 samples and groups were exactly the same except for the treatment, and thus this gives us better validity for our judgment that there is no difference in resolution time. So what does this really mean to patients? So if you go back to the example I gave you, let's say you were the pediatrician with this patient with Kawasaki's. But let's say this patient was severely had some past medical history which indicate that steroids, a synthetic hormone to an infant, may not be a better option, and maybe pumping more IVIG would do better good. Or maybe you found that the IVIG is consistently not working, and maybe trying steroids would be the better option. Thus, doctors have the full disclosure to do what is best in their medical decision, knowing that either option they choose would be equally as effective in resolving these coronary artery abnormalities. And to explain why some of these things why both treatments could be effective, is I looked at a study done by Sujimoto in 2002, and he found that IVIG actually induces the cell death of programmed cell death, the apoptosis of white blood cells. In in vitro experiment, he measured these neutrophil levels, which are white blood cells, before and after IVIG treatment, and he found that IVIG increased the amount of apoptotic cells and decreased the amount of total white blood cells, which kind of points to the sense that IVIG is a good way in a negative feedback system of decreasing the total amount of white blood cells that could harm the child. And contrastingly, a study done by Okada found that steroids could also be a novel way and different methods. Steroids could often act as an inhibitor to inflammatory gene expression, specifically the interleukins, which are immune signaling proteins, and they could often block these pathways and prohibit the mass surge of cytokines that could potentially harm the patient's blood vessels. But also one interesting idea that I found was that in Han's study in 2000, I found that the scope of this research could be generalized much further. Now, this isn't really done very often, but what he found was that the treatment response for any patients is irrelevant of their demographics, their age, their symptoms, their location. Thus, I could say that according to Han's study, my population could be extended to all children with Kawasaki's, and I could further validate the idea that for Kawasaki's in general, both treatments could be as effective in eliminating coronary abnormalities, whether you're in Boston, in Singapore, or in Japan. My future directions involved a few things. These 5 points summarize my research. It clears up the controversy to some degree. It provides reliable and original data from these public hospitals. It is a new population that hasn't been studied before, and also it's observational and clinical, thus we can make inferences about actual hospitals, and we can predict that these outcomes would be the same. And thus these quantitative variables also allow us to maybe adjust some things quantitatively and have such certainty that our data is truly valid. But I still have some next steps, as this is only a single step towards clearing this controversy up. There has to be more multi-center perspective randomized studies to ensure that my data is increasingly valid, and you conduct more population studies on more groups to ensure that my data isn't biased and that we're achieving consistent results. Thank you.
Thank you, so we will go ahead and start with the oral defense, and I know you talked greatly about the obstacles that you had, but can you just focus on one specifically and talk about that challenge and how you addressed it?
Yeah, my biggest challenge was I had this data, I had a gigantic spreadsheet with all these measurements, but I knew that I couldn't just compare this. And like I said in my presentation, there had to be a way to standardize it. And when I read McCrindle's paper to standardize, it was extremely convoluted, and I could not understand how he got from like this standardization to this weird linear like normalization to this formula. But I eventually got the idea that if you apply these formulas to essentially normalize each artery measurement, you could essentially compare the abnormality amount instead of the actual measurements. Thus, I could say that my data is more reliable because I compare the right things, really, right? Not comparing things that shouldn't be compared at all.
Thank you.
Thanks, Sanjay. I really enjoyed the progression through your research. So I want to ask a question about the depth of your understanding. What additional questions emerged from your research?
The biggest question that emerged from my research was not only like why exactly does IVIG or corticosteroids work, is more the pathophysiology, like why which causes link to how the treatments work. Like I said in the beginning, Sun and Neuberger found that all these ideas as to what causes Kawasaki's was eventually all turned down, all denied. And I want to know exactly what causes Kawasaki's, so we have a better understanding and a better way to treat it scientifically instead of through empirical evidence, which I find can be very based upon research like mine.
Mm-hmm. So what advice then would you give to researchers in the field?
I would say the biggest thing is make sure you know where your scope is, because coming in I thought that I could do an experimental study, a prospective one that could like assign treatments and assign roles and measure over time, but I realized that my scope and my idea was slightly off, and I should really focus on retrospective ideas and focus on treatment that has already been received, and focus on maybe not doing experimental but an observational one that is more feasible and more reliable for really an empirical clinical study.
Thank you.
Sanjay, I want you to think about the initial curiosity that led to this. You talked about how you kind of had to change direction after you realized your scope. So given that initial curiosity, okay, what other areas of inquiry might that same curiosity lead you to?
Well,
in different directions and so
I may have kind of pigeonholed this topic into just two treatments, IVIG and corticosteroids, but in reality there are many more treatments like infliximab, aspirin doses, hydroxychloroquine, and I found that while I chose the two most prominent ones used in medical studies, the fact is there are other treatments that haven't been necessarily implemented scientifically but are hypothesized in many different ways, and I found that maybe branching out to these different treatments could be a good way of expanding and trying different ideas in this research. Thank you.
Sanjay, congratulations.